Hi, I'm Dr. Nicole Tartaglia, and we are here today to present a talk called Beyond Hormones, and we will be talking about other medical conditions and physical symptoms associated with X and Y variations.
As we get started, I'm going to hide our screens here so that you can see all of our slides and just know we're talking or know who's talking in the background. All right, go for it.
Okay, so in terms of an outline, we're going to do a little overview and talking about medical problems in infancy and early childhood. And then Dr. Davis is going to take over and talk about more of a big picture and systems perspective of the different medical problems in X and Y variations. And then we're going to go through a few examples of some very specific and common conditions that we see. As a note, in the question and answer session at the end, we can't provide specific or individualized medical advice, but can answer general questions about medical care and follow-up recommendations. So this first presentation I'm going to present is on data from the Extraordinary Baby Study. This is a natural history study that we've been doing both here in Colorado and also at Nemours, led by Judy Ross at that site. And we presented this data at the ACMG meeting in March of this year, 2023. And actually, Susan Howell was the first author and won a prize as one of the top posters at the meeting, which is a huge genetics meeting. So we were very enthusiastic about sharing our work there and about her award. This talks about infants only in the first year of life. So our study is a long-term study, but we did the analysis on infants who had reached 12 months of age. So there were 252 infants included. You'll see the color coding of XXY with 172 infants in green, trisomy X in purple, and XYY in blue. Overall, 95% had been identified prenatally by NIPS. Mean maternal age was 35, mean paternal age was 37, and most were full-term babies, and 33% were delivered by C-section, which is the typical C-section rate in the general population. Overall, when we looked at birth size, it was slightly lower in XXY and trisomy X compared to the mean. But overall, when you looked at that percentage of individuals who actually met criteria for SGA or small for gestational age, you can see that it was only slightly higher. And on average, the distribution looked pretty similar to what we expect in the general population. In general, perinatal history, so pregnancy history and birth history were unremarkable or did not have differences from what we would see in the general population. Next, we looked at physical exam findings. So this is a list of the most common to the least common physical exam findings. And you can see here the top ones include epicanthal folds, which are kind of small folds on the insides of the eye, clinodactyly, which is a curving of the fifth finger, and then hypertelorism, which is a slightly wide set eyes. And then we also saw high rates of hypotonia or low muscle tone, as well as torticollis, which was usually what we call positional torticollis, with a slight shift of the head or tilt of the head with preferential looking to one side. All of these conditions, the folds, clinodactyly, hypertelorism, do not have any impact on function. So there's not any visual impacts from them. There's not any functional hand impacts. And torticollis is often treated with just positioning and stretching exercises, or if needed, physical therapy. And then very rarely it can lead to some plagiocephaly or a not round head that occasionally needs to be treated with a helmet type of therapy. The rest of these diagnoses down here are all things that we saw, more frequently than we might expect in the general population, but not very commonly. Interestingly, cryptorchidism, which is undescended testes at birth, and microphallus, which is a short penile length, were both very rare in our population, and these are lower than we expected compared to what we see in the other medical literature. A proportion of our infants had also had either echocardiogram or ultrasound of the heart or ultrasound of the kidneys, and we found abnormalities in about 22 to 23% of those who had been imaged. Now, you know, sometimes there's a reason for imaging. They heard a heart murmur or some other concern. So this is a number that we think is probably higher than if you measured the entire cohort and did studies on everyone, but we haven't been doing studies on all of the infants. But because of this, we looked at, you know, exactly which of the features were present. Most of the ASD or VSD, the septal defects, resolved with time. Others that hadn't resolved were just being followed, mostly without symptoms, and there were just 2 surgeries that were needed for these challenges in our cohort. We recommend now an echocardiogram or a heart ultrasound and kidney ultrasound after birth for screening for issues that may need to be followed. And then as we learn more through the study, we'll be able to make more solid recommendations related to these findings. Another common finding were breastfeeding difficulties. We saw breastfeeding problems in about 50% of our infants. These were primarily latching difficulties, difficulties with latching to the breast when attempting to feed, and it was associated with failure to thrive, earlier introduction of formula, and then also frenotomy, which is also sometimes called frenulectomy, or a clipping of tongue tie. And whether or not this actually helped or was just done because of the breastfeeding problems in attempt to try and help it, we need to do more investigation of. The take homes from this are that we really want to make sure that people are aware that breastfeeding problems are common. Breastfeeding and lactation consultation and support are recommended, especially if there is, you know, very little education about breastfeeding and or previous problems with breastfeeding. Pumped breast milk is an alternative if that latch is not able to be successfully treated with lactation support. And then also infant formulas are very safe and well accepted as a substitute. Medical problems within the first year of life, we saw a lot of medical problems that are common in the general population: acute otitis, which are ear infections, bronchiolitis, other infections, and febrile seizures, which were very low. And all of these were generally at the same rate as we would see in the general population. So not more common, but we did see slightly more were hospitalized over time. 12% had been hospitalized, with 18 being hospitalized for respiratory infections. And that to us just means that while they don't necessarily get sicker more frequently, sometimes when they do get sick, they may get a little bit sicker and need hospitalization, especially for respiratory reasons. 10% had surgeries for various reasons as well. And then other conditions we saw that were more common were GI conditions, reflux, failure to thrive, constipation, and 55% actually had some sort of atopic condition, which includes eczema, food allergies, reactive airway disease, and these were some other conditions that were uncommon, but still higher prevalence than we expected in the general population. I want to spend a little bit of time because that previous report was on the trisomy conditions, and we also have included babies with XXYY, 10 babies with XXYY in the study, and 2 babies with XXXY. And these are much lower in terms of sample sizes, but they're also much less common than the trisomy conditions. And here you can see the age range in this cohort goes beyond 12 months. It goes all the way to 5 years of age. Now, some of our infants have not quite reached 5 years of age yet. Some are still in their first year of life. So this is not, you know, some of these may still emerge as having some of these medical problems here. But what you can see is, in general, the same medical problems that were high in our trisomy population are also high in our tetrasomy population, and sometimes a little bit higher. Like eczema in this group was 83%, torticollis was about the same, 41%. And so, you know, overall, from all of these findings, we generally see the same types of medical problems, sometimes to a more severe degree or more frequently, and sometimes more often seeing some slight physical malformations more often than we see in the trisomy conditions. Okay, Dr. Davis.
All right. So this is taking a little bit of a step back now. We want to go all the way from infancy all the way to adulthood. And this is because a lot of the research that we know that's in the literature before we've done work here at the Extraordinary Kids Clinic has been done in adults. And so you may have heard of some of the studies that have been done in Denmark and the UK that are based on what we call registry studies there, or the population studies. So in these studies that they've published, they've looked at all 3 trisomy conditions. They have not yet looked at any of the tetrasomy conditions yet. But the big picture here is that in all of the systems, when you look at all of these different things that you could possibly be diagnosed with, from infections to cancers to blood disorders to endocrine things, psychiatric, neurologic, you don't need to read all of these. But what they have concluded is that it seems like there's not just one system involved here. The extra X or the extra Y chromosome seems to involve really multiple systems throughout the whole body. That being said, not everything is involved, and certainly not every individual is affected with this. This also doesn't let us know what specific conditions within these big, broader systems are affected either. And so we're going to talk a little bit more in depth about that. But the big picture here is that we know that there's an increased risk from sex chromosome trisomies for multiple different medical conditions in adulthood throughout multiple different body systems. Next slide. So we then tried to replicate this. We don't have the big big studies that they do in Denmark where they can look at the entire population of an entire country, but we are starting to gather some bigger data here in the United States as well. One of these studies is called PedsNet, which is a collection of at least 6 large children's hospitals. When we received data a couple years ago, we had 6 hospitals represented and more than 6 million children in this database. And we actually had in there 1,700 kids with diagnosed sex chromosome trisomy. So either XXY, XYY, or XXX. Again, you can see the categories here over here. One of these, I guess I didn't describe this, what's called a forest plot on the last slide to you. Anything that is crossing 1 means that there's no difference between the general population and the individuals that you're looking at. So XXY, XYY, or XXY. So you can see here that most of these categories that we looked at actually crossed 1, or some of them were even a little bit lower risk. And we're not going to get into why that might be. But there were a few that were higher. So conditions that fell into the nervous system category were higher in childhood. Conditions that fell into the mental health category, the endocrine category, and the cardiovascular category. However, overall, this is much more positive than what the adult studies in the other countries had shown as far as how much of the system is affected, at least in childhood. Go to the next slide. Some of the questions that still remain here, though, are certainly, these are just representing individuals that are diagnosed with sex chromosome trisomy. And we know that the majority of individuals really live their entire life without ever receiving a diagnosis. That is, of course, changing with the non-invasive prenatal screening, identifying kids much earlier in utero and then shortly after birth. And so when we're providing counseling to those individuals that may never have received a diagnosis in the future, these data that we're looking at may or may not apply. So that's important to keep in mind. And then most importantly, what does this mean for my child? And so we're going to look now a little bit deeper at some of the actual medical conditions that we see that we at least want to talk about. We can't talk about everything, but flip to the next one. So the first one, Dr. Tartaglia already discussed. We see an increased risk of congenital heart disease and kidney differences. These are structural differences that you would be able to identify through imaging, an echocardiogram or a renal ultrasound, sometimes even in utero before the baby's born, or certainly if you did the imaging afterwards. We don't expect new things in this area to suddenly be present after birth. These would be things that they're born with. Next. So from the neurological systems perspective, we do see an increased risk of seizures, certainly not the majority of individuals, but it is higher than the general population. And then tremor, we're going to talk about in a little bit more depth on the next couple of slides. From the GI perspective, we see an increased risk of constipation and GI or abdominal pain, as well as eosinophilic esophagitis. We will talk about the everything in purple we're going to talk about in more depth here. We see an increased risk of dental problems, including differences in dentition that lead to worse caries or cavities, even though they might have great oral hygiene. There's also some differences in the root development that we can see in XXY individuals as well, but certainly a lot more research that we need to do in this area. And then strabismus is a crossing of the eye, either a deviation inward of one eye or a deviation outward of another of an eye. And this may need patching or drops or surgical care but it is pretty obvious to be able to see and can be picked up on an exam. Next, we're going to talk about a lot of the musculoskeletal conditions in the next few slides, including problems with the spine, problems with the arms, flat feet, and then I think I had one other, there we go, osteoporosis as well. Osteoporosis is weak bones that can predispose you to have increased fractures later on. We also, as Dr. T already mentioned, and saw in the infants already an increased risk of atopic conditions like eczema, allergies. In adulthood, or in childhood, that evolves into asthma. And then we're going to spend some time talking about thrombosis as well as cardiometabolic health on the next slides as well. And fatigue. There you go.
Okay, so I'm going to spend a little bit of time going over some of the musculoskeletal findings that are more common. Again, for all of these things, individuals with X and Y variations are at risk for having these challenges. A lot of the literature gives us percentages, but these percentages are often biased by the population of patients that are in the study. So again, like Dr. Davis was pointing out, don't always represent the entire population because many individuals are undiagnosed and so may or may not have some of these findings. So the first one we talk about is called pes planus or flat feet. And what you can see here is, a picture of what it looks like. This is a more significant case where there's no arch in the foot and we see what we call pronation. The easiest way to look at pronation is from the back of the feet. And so this is what we expect to see, a nice line from the leg down through the ankle to the heel. When they're pronated, you can see from flat feet, you can see a little bit of an angle. And then when it's very pronated, you can see a bigger angle. We can identify this on physical exam very easily, and so any physician can look for it. We treat it only if it's impacting gross motor development or physical balance, and also if there's pain associated with it. So if there's pain in the feet, the legs, or even the knees can sometimes have referred pain from flat feet when there's walking or high levels of physical activity. And so we recommend PT, physical therapy, or orthopedics consultation related to whether or not there's a need for arch supports or orthotics. And then in severe cases, so, much more significant than this, sometimes there can be surgery that's necessary. There's lots of different types of orthotics that can help with arch support. And then we also recommend a lot of supportive shoes. New Balance, ASICS, Under Armour, and Saucony are some of the best ones for good arch support and flat feet. Another condition that can happen more commonly in X and Y variations is called radial ulnar synostosis. And this can occur in any of the conditions, but is more common in the tetrasomy and then the pentasomy conditions as well. So what this is the radius is, the radius and ulna are the two bones of your forearm. And there's an abnormal fusion of the radius and ulna at the proximal end or near the elbow. So here you can see an X-ray that has a synostosis. So this is normal with the two bones, and this is a fusion. And the reason why this is important important is because when you do these motions called supination or pronation, you need to cross those bones. And if they're fused, they obviously can't cross. Or if they're fused to different degrees, sometimes they can only cross partially. So what you see here is a young man who was an amazing young man with XXYY, and he had radial ulnar synostosis. And this was as much as he could pronate. And so he could not get his hands flat because he couldn't do that full rotation because of the fusion of the bones. This usually is not treated, but it is important to be aware of it because sometimes it can limit range of motion, and you can't always tell it's there and without a good exam, because you can make up a lot of that range with your elbows, but then sometimes it can be harder. And so sometimes we need some occupational therapy or physical therapy just to help us accommodate. But very rarely does it need surgery or intervention and is not painful. Some other musculoskeletal concerns are called kyphosis and scoliosis. These are differences in the spinal or the positioning of the back. So here's a nice healthy spine. In kyphosis, you have a position where the spine is bent forward, especially at the top. And then scoliosis is a curvature abnormal positioning that you can see more often from the back. And so both most commonly emerge in adolescence, and both are likely partially due to lower muscle tone and kind of increased ligamentous laxity that we see in the X and Y variations. But scoliosis likely has some additional contributions often. The kyphosis is usually what we call postural kyphosis. And when it's postural, it means it can be helped with back strengthening exercises, with physical therapy, and then sometimes even posture correction braces. And you can see here a girl who has and is showing what postural kyphosis can look like. And a lot of this is also brought on by, a lot of screen use or phone use. And so that's really important to know about. The important thing here is that you can often correct it, right? So there's a lot of strengthening exercises, like I said. Now, scoliosis should be something that the pediatricians and care providers are monitoring for yearly from childhood. It's less common than the postural kyphosis, but it's important to follow because with worsening scoliosis, you may need bracing or surgery, but very rarely. So this is the test that we do. It's called the Adams forward bend test, and the doctor will look at the back and look if there's any abnormal curvature of the spine or asymmetry. And here's an example of some mild scoliosis in the back of a young man. So if you're concerned, you want to ask about your primary care provider about referrals to orthopedics or physical therapy for further evaluation. Sometimes they'll do x-rays for scoliosis. And then think about positioning of screens, right? If you're hunching over looking at a screen compared to having a screen straight in front of you where you have to sit up to see it, that makes a big difference. Obviously, we want to try and limit excessive screen time, but if you are going to use it, at least put it in a place where you're not going to affect your body posture. Okay, the next condition I want to talk about is called EOE. It stands for Eosinophilic esophagitis, which is a really long, fancy term. But basically what it means is there's inflammation of the esophagus with a certain type of white blood cell that are called eosinophils. So the esophagus is a tube that goes from your mouth to your stomach. And then over here, you can see different degrees of eosinophilic esophagitis. So what happens when there's that inflammation is this is normal, and then you get more and more eosinophils, and then more and more thickening of that esophageal wall. And as you get more and more thickening, it doesn't work as well. It doesn't have that normal peristalsis that helps the food get down. And it also can lead to fissures and all sorts of other types of challenges from that inflammation. So we started hearing about this from individuals first in our XXYY project a long time ago, and then it's just kept coming up in our clinic. And so we did a retrospective study where we looked at over 500 individuals who had come to our clinic and looked at those who had been diagnosed with EOE. And it was 4 to 5% of all kids in the clinic. That gives us an odds ratio of 32, so 32 times higher odds of having this compared to the general population in kids, and likely even higher in adults. The importance of this is that even not everyone in our clinic had been tested for it. And so we think it's likely higher than this. It's very commonly associated with food allergies, asthma, and eczema. And the symptoms that you see, one of the biggest symptoms we talk about is dysphagia or discomfort or pain with swallowing or difficulty swallowing. So people will say things like, they feel like food is getting stuck in their throat. They avoid foods that are harder to swallow, like steak or other meats or bread. They have to cut it or chew it for a very long time to get it in small enough pieces to swallow. They drink a lot of water with meals to get the food down, or use a lot of sauces. Or sometimes there's even this like head and chest movement that people will have to kind of like move their head back to help them swallow the foods. When you look here, it can present differently at different ages. And so while in the younger kids, dysphagia, was the most common presenting symptom, and in the older kids in the study. We only included pediatric patients in this study, but it definitely can still present and be present in adults as well. And then you can see the other symptoms that sometimes happen. Reflux is associated with it, abdominal pain, being underweight, some really thin individuals that didn't know why they were so underweight, vomiting and gagging, food impaction or food actually getting stuck in the throat. And that's usually more common in older individuals or adults. And then this can sometimes actually also be pill impaction, which is, if you're swallowing medications and they get stuck. And then other feeding difficulties, especially in infancy, with choking and gagging, chest pain, and then esophageal spasms. So if you're concerned, if any of this sounds familiar, you want to talk to your primary care provider about a referral to see a gastroenterologist. You can bring along this How Will It All paper. We'll provide it as a reference in the conference materials. And then for definitive diagnosis, you have to have an endoscopy or a biopsy of the esophagus. Often people will first start treating it with a trial of reflux medication and then determine if endoscopy is necessary. And then finally, I'm going to talk about tremor. This is a tremor that's usually limited to the upper extremities. It can present anytime from childhood to adulthood, and sometimes progresses with age, but sometimes stays stable. We estimate that anywhere from 5 to 22% in the trisomy conditions, and up to 70% was present in one of our studies in adult males with XXYY. It definitely is very variable in terms of its severity. It can be very mild or more significant. And the treatment really depends on the degree of impairment that it's causing. So we ask questions like, are there any problems caused by the tremor? Are there problems with handwriting? Is it affecting self-care skills such as dressing, buttoning small buttons, eating with utensils or spilling, pouring liquid and, spilling liquid when you're pouring, and then any other functional or work skills, like if you need to, use a screwdriver at work or any heavy machinery that it's affecting. And then other hobbies. I have one young man who was really affected and upset by it only when he was painting and doing art, which was, one of his hobbies. And that's important to have that as as an outlet and opportunity as well. And then if it's affecting, you're really self-conscious of it, or it's affecting you socially or in terms of self-esteem. So the recommendations for treatment include occupational therapy for accommodations, supports in school or work, for definitely instead of handwriting, doing some keyboarding, weighted utensils. There's lots of other adaptive tools for tremor. And then we also use medications either, all day or as needed. There's propranolol, and then there's many others as well. So you want to talk to your primary care provider about a referral to see neurology. They'll usually rule out other causes of tremor first. It's important to know many medications, especially medications that may be used frequently in X and Y variations, like stimulant medications for ADHD, Depakote or lithium, SSRI medications for anxiety or depression can also contribute to tremor. You don't have to stop them if it causes tremor, but you want to stop them if it causes tremor that's causing a lot of impairment. And then other medical and neurologic conditions can cause tremor also. So those are important for the neurologist to think about.
Okay. Now we're going to shift gears and talk about blood clots. So this is something that we have also appreciated in our clinical experience, but certainly also in the literature as well. So blood clots can look like several different things. The most common two that we think about are DVTs, or deep venous thrombosis, which can occur usually in the leg, often in the calf, or in the arm. And then if that clot breaks off, it can actually travel to the lungs, and you can get a blood clot in the lungs, and that's called a pulmonary embolism. metabolism, or PE. We clearly see an increased risk in XXY and XXYY. In fact, the literature that we're looking at says over 20% of individuals in their lifetime will have at least one blood clot or more with these conditions. There's less clear information in the literature about whether or not this affects XXX and XYY. However, we are working on some data right now that does suggest we see similar results in these groups as well. We know that this increases with age, both in the general population and certainly in sex chromosome aneuploidies as well. It's very uncommon to see this before puberty, but starting in adolescence, certainly if they're in a provoked situation, we can definitely start to appreciate an increased risk of blood clots. Importantly, it's not due to testosterone replacement if you are getting testosterone. And I want to emphasize that because I've had several of my patients have their testosterone stopped if they present with a blood clot, and that is not necessary. The symptoms of a blood clot, it depends upon where it's at, but if you have it in your legs or your arms, you can have a crampy feeling, tenderness, throbbing, or pain. Swelling or discoloration are often observed. If, however, it's already gone to the lungs, that can present with sudden breathlessness or back pain with breathing, especially taking breaths in. There are certain situations that put you at higher risk for developing blood clots, and this includes having a central line, so a line that is delivering medications, for example, centrally, like to your heart. This would be if you're in the hospital for some reason. Surgeries, especially orthopedic surgeries, and then anytime you're immobilized. So if you are in a long car ride, for example, and are not getting up to walk around, or plane rides, really important to try to minimize that risk. And then for prevention, in addition to obviously avoiding any high risk situations that you can, some of the most important things that I want to emphasize are not smoking, because we know that smoking definitely increases your risk of thrombosis, maintaining a good weight, because we know that it's associated with obesity. Moving, as I mentioned, immobilization is one of the biggest triggers. And then making sure that you tell doctors about this risk, because many doctors will not know about the risk of thrombosis in sex chromosome aneuploidies. And if you're in one of these high risk situations, like going in for surgery or needing a central line for medications or something, your doctor should know about that so that they can give you preventative treatment. Next, moving on to the category that I call cardiometabolic disorders. These are a whole bunch of conditions that kind of fit into the same family, including things that put you at increased risk for type 2 diabetes, heart attacks, and strokes. We know that there's an increased risk of a lot of things in this category in X and Y variations. We've done studies even in kids and even in babies that show adiposity, or your percent body fat, is higher than in typical kids, even if you're not overweight. So don't have to have a obesity or to be overweight to have an abnormal adiposity picture. This often makes you resistant to the hormone insulin, even if you have no symptoms, which is really important to emphasize. It's really important to know that the leading cause of both morbidity and mortality from a medical perspective is type 2 diabetes and cardiometabolic related things, particularly in XXY, although we certainly can appreciate this and the other conditions, just less researched, really. So if you can click on the next slide, thank you. So what can you do about it? I think really emphasizing, prioritizing a healthy lifestyle. Again, even if you are normal weight, you are unfortunately not protected completely from these things. And I think physical activity is one of the best things that you can do for this from very early in life. Starting in adolescence and maybe even younger, if you have other risk factors like obesity or a family history, we want to check some screening labs, including a lipid profile to look at your cholesterol levels, and A1C to look at what your blood sugars are on average, and also to look at your liver function, because if you have abnormal fat tissue, it can get put in the liver pretty easily, and you can get something called fatty liver disease. We do recommend, if there are any abnormalities that are identified, really actually approaching this pretty early and aggressively. So not just waiting to see, oh, maybe this will just go away, maybe this is minor. We know that this tends to progress over time. And so actually addressing this with, if you are overweight, weight loss programs, or considering medication, or even bariatric surgery is a very promising thing in the general population. Certainly has never been studied, particularly in X and Y variations, but for significant obesity is very helpful. And then finally, addressing any comorbid health conditions that might go along with cardiometabolic disorders and make it harder to lose weight or get healthier. Things like mental health conditions like depression and sleep apnea, pain that might limit your ability to move, etc. All right, and then my last one of the most common complaints I hear about in clinic is fatigue. And this can look like, well, man, he just needs a lot of sleep. Like he sleeps longer than the rest of my kiddos do at home. Often we have babies needing, 17 hours of sleep even, kids and toddlers still needing, 12 to 13 hours of sleep. We hear as they get older, falls asleep very easily in many different circumstances, class, in the car as soon as we start driving, in clinic on my exam table, etc. And that we also can sometimes hear that they can't do, or they have difficulty doing prolonged physical activity. So things like walking or hiking with the family and things like that. We also can see sometimes this doesn't necessarily present as like actually sleepiness or fatigue, but sometimes, when they have really long days or intense days, they just get wiped out way easier than their other kids do. And this can result in more tantrums or worse behavior. Unfortunately, we don't know the reason for this fatigue and poor endurance. And certainly, I should say, again, just like everything, this isn't every kiddo with X and Y variations or adult with X and Y variations. This is a subset that we're still trying to figure out. We do have some research going on right now that suggests that maybe there's an actual difference in energy metabolism, or how your body is actually taking the food that we eat and making it into energy that cells can use. So what do you do about it? I think, again, prioritizing those healthy lifestyle habits with the focus on physical activity and with that focus from a very young age. We know that increasing endurance will help long term. We also want you to consider some other comorbid conditions, including sleep apnea or other sleep disorders that might be contributing to making you more tired during the day or not needing more sleep at night. If ensuring testosterone and other hormones are in the right range or treated if they're not in the right range. Checking for other conditions, including anemia or iron deficiency or inflammation or hypothyroidism that could be contributing to fatigue. And then if you've ruled out all of those things, potentially considering supplements. We have heard, at least anecdotally sometimes, that there are some supplements that may help, things like creatine or protein powders. We certainly have not tested any of these, and we don't necessarily recommend that as medical advice, but as long as you talk to your doctor, there could be some things that you could at least try. And then finally, we are, as I mentioned, doing a research study so that we can figure this out more. If you click on the next slide, we have on our website, it's extraordinarykidsclinic.org, a list of our research protocols. And one of them that I want to highlight in particular is called Lipids to Energy, where we are looking at how the body is able to use fats and turn them into energy for those more prolonged activities that seem to produce more endurance for these individuals. So with that, I think that we are wrapping up, and I will go ahead and pause our recording so that we can take questions. Thank you for your attention.